Okay, so this video is for lumbar arthrogenic case studies. So lumbar arthrogenic, again, we're thinking about our passive range of motions, we're thinking about pivums, pavums, palpation of soft and bony tissues, and then finally special tests within this section as well. So to start off with, we've done our observation or active range of motion, combined movements. We're now moving on to do our passive range of motions. So I don't have a pillow, as I say, with me today. We would have a pillow in place for these tests. Just get you to have a lie on your back with your head at this end. Okay, so for passive range of motion, we've got lumbar rotation and flexion, the two tests we've done. For rotation, it would be knees bent to your feet just on the bed there. Support the weight of Tom's knees. I'm going to passively take his knees down towards the left. What I'm watching for is when the thoracic spine starts to take over. So you'll notice that the kind of hip lifts up, so that's all lumbar. And as I keep going, it will start to be rib cage that lifts, so that now becomes thoracic. Okay, so I'm just isolating the range of motion to the lumbar spine. Then do the same towards me. And again, I'm observing how much lumbar rotation Tom's got there in his back. Comparing left to right. Reproducing symptoms, stiffness, those kind of things with these tests. Again, with our passive range of motion, our differential diagnosis is that if it was painful when he did it actively, but not painful when we did it passively, it's probably something contractile that's causing the problem, like a muscle. Remember, with the lumbar rotation, we don't have a huge degree of movement because the facet joints are orientated at a 90-degree angle. Therefore, there's not a great range of motion that can occur at the lumbar rotation anyway. We have a lot more lumbar flexion though, so we can test passive range of motion lumbar flexion by pushing the knees up into the chest and allowing the tailbone just to lift off the bed. So passively taking Tom into lumbar flexion. Again, any problems there? Feel okay? Good. And then we can use our clinical reasoning again to aid our diagnosis as to what's happening. Remember, the purpose of this test isn't to diagnose at the end, but it would be nice if you could show some clinical reasoning around what sort of tests you're doing for what reason. For our passive physiological intervertebral movements, which are our maintenance techniques, we've got flexion, extension, side flexion, and rotation in 3 different places or 3 different movements. The idea of these is we place the fingers of one hand in between each spinous process. Our other hand is doing the mobilisation. Remember, it's passive physiological movement, so one that the patient can technically do themselves anyway, and we're feeling for what happens with the fingers in between the spinous process. We're looking to see if there's an even amount of movement going on at each level, or whether one level is doing all the movements and the other levels are staying stiff. Okay, so you got to have a line your side towards me this way. So as I say, I normally have a pillow here, so it might well be a little bit uncomfortable in that position. You okay, Joanne? So this hand I'm going to place in between each gap in the spinous process on the spine there. This hand I'm going to scoop the top leg up and use my forearm to support it. Good therapist mechanics down into that squat position again. And for flexion, I'm just taking the knee in towards the chest. Nice kind of smooth movement. And with my left hand on Tom's back here, I'm just feeling for where the movement's coming from. So because we're going into flexion, it should feel like the gaps between each spinous process get wider as I go into flexion, and they close together as I come back towards neutral. Extension, we're going the other way with the leg, so taking the hip into extension. Again, use your mechanics so that you're kind of leaning with your body weight rather than just your arm as you come through. And this time it should feel like the gaps between the spinous process get narrower. Same as everything, we're reproducing symptoms. Looking for stiffness, looking for where the movement's coming from. We would then do the other side. We won't do that for the purpose of this video, just so you can see everything from this one angle. We can compare one side to the other. However, while he is still on this side, we can move through all the other pivums first before we do get to roll over. So the next one after flexion extension would be rotation. So for rotation, the important thing is you put your hand underneath the top arm and then put your fingers in the gaps. And that's just so we've got a bit of a lever and a bit of a barrier for the patient to pull against. My other hand's on the pelvis, with my forearm in line with the femur, and then I'm providing a nice gentle rotational movement, pulling this way with this hand in line with the femur, and just feeling where the rotation's coming from within the lumbar spine. Remember, there's not a lot of rotation here, so we wouldn't expect to see a huge amount of movement. The second stage, though, is we can put him in a little bit more rotation by bringing the top leg up, straightening the bottom leg down. Same again, fingers in the gaps, going in line with the femur. See there's a bit more rotation there. And then finally just hold that position with your legs. With this hand, if you reach around for my shoulder blades. pull that shoulder through. So again, we're rotating the thoracic spine the other way. And again, I can provide that rotational movement here. So we're kind of entering the realms of treatment now as well. So these techniques, if they're stiff or they feel quite nice to be mobilised in these positions, are good kind of treatment positions as well, which we'll look at learning in third year. For side flexion, we're going to go back to that start position, so knees together and just untuck that shoulder back through again there. Hand underneath again, fingers in the gaps, hand on the pelvis. Rather than pulling this way now, I'm going to be pushing that way towards the foot end. Okay, so I can push towards the foot end there. And now we're doing that passive physiological intervertebral movement for side flexion. One of the tips I've taught you in the sessions is if working with females, you naturally have slightly wider hips because of childbearing. We might notice that the patient actually starts in a degree of side flexion in the opposite direction. So when performing the test, we're technically only taking them to neutral. So what we might be able to do there, or might have to do, is put a towel or a pillow underneath the pelvis or underneath the kind of mid-back so that we've got a neutral starting position there. Okay, so that's our passive physiological intervertebral movements for the lumbar spine. Our next stage then would be to do our pavums, our passive accessory intervertebral movements. So you got to have a line in front again there, Tom, just head at this end. So we have bigger spinous process and bigger transverse process in the lumbar spine. So whereas we used our thumbs for the cervical, we can use the soft bit just above our pisiform to provide the mobility for these exercises. So we know our bony landmarks that we can use as our reference guides now. T12 is the bottom rib, L4 is the iliac crest, so we can count up and down from those levels. So we're going to work through each one, hand on the spinous process from a passive accessory intervertebral movement, posterior to anterior pressure. We're going down, but again with that slight upward inclination. Okay, we're going to work through each of those spinous process. Remember your grading system here as well, so for assessment purposes we're going to be quite gentle to start off with, and we can get a little bit deeper into the grades. But if we were doing these for mobility techniques in terms of treatments, that's when we can use our grading system to kind of work out how hard or how much we can mobilise based on the severity, irritability and nature of the patient's symptoms. While we're doing lumbar, in this position we might as well do our sacral one as well. So it's heel of the hand on the sacrum, reinforced with the other hand, and again we're just providing a direct downward pressure this time, no need to go upwards. Reason for this one is to see if it provokes pain. So people who have sacroiliac joint pain may report discomfort or reproduction symptoms with this test. Remember, the sacroiliac joint only moves 2 to 5 degrees, so we wouldn't expect a massive amount of movement here, but it's a test that's worth doing as we've gone through our lumbar pavements here. We can then do our unilateral PAs for the lumbar spine in this position. Remember, the transverse processes are a lot wider than they are in the cervical spine, so rather than being a thumb width away, we might have to go a little bit wider. And we'll know if we're on bone or soft tissue because the bone will offer a little bit more resistance when we prod into it, whereas the soft tissue is a little bit more springy. Okay, so again, using the bit above the pisiform, reinforced with the other hands. Good mechanics, so lock your shoulders out, contract your scapula, use your body weight to provide the pressure. And work our way down the left side of the spine. And then what I'd suggest is going the other side of the bed to do the right side of the spine, rather than getting your handling the other way around by coming across. The transverse glides here, which are performed on the tip of the spinous process, aren't performed in prone as they are with the cervical, they're performed in sideline. So you just have a line your side just facing this way again. Okay, so this time I can find the spinous process, the bony bits that stick out. My thumbs this time, because I've got a more specific spot I'm aiming for, on the tip of the spinous process towards the top end, reinforced with the other thumb, and then I'm pressing down, very subtle pressure. Remember, it's just a small amount of pressure here towards the bed. Okay, so I'm going directly down towards where the bed is there. And I can work my way through. Coincidentally, although this is the lumbar spine, if you had a thoracic case study, it'd be lower or upper thoracic. For the lower thoracic, we can do these same side transverse glides for the thoracic spine in this position as well. Okay, just need to have a line in front again. So our final stage then of arthrogenic in prone before we do a special test is palpation. So palpation is bony and soft tissues. Bony tissues we've pretty much just covered with our pavums. Okay, so we've gone through our spinous process, transverse process, and sacrum. For soft tissues, the ones that we've done have been erector spinae, so we can palpate along erector spinae. Remember, this is where you can get your extra anatomy points, so you can talk about the three erector spinae. We've got iliocostalis, longissimus, and spinalis, so working from lateral to medial. The other trigger points we can do here would be for the quadratus lumborum, which goes from the iliac crest to the bottom rib. So we're going in that kind of diagonal line in there, and again we can compare one side to the other. Is one more active or tendon compared to the other? And finally the piriformis, which goes between the greater trochanter and the top of the sacral hiatus, and again we can provide that kind of trigger point pressure indices through that muscle. So palpating it, we can kind of identify if it brings on any symptoms down the leg. So you have a stand there, Tom? Okay, so final part then is a special test. You need to stand this facing that way. So this is a special test for the pars interarticularis, also referred to as a spondylosis. So this is the kind of area of the spine that can become injured with repetitive extension and rotation. So things like tennis players and bowlers in cricket, usually more adolescent, so a test that's worth doing for anybody kind of in their teenage years with lower back pain on one side. So you just stand on your right leg, that's it, and then with your hands on your hips, and you need to bend backwards. So my hand here is just for support, I'm not providing any assistance. It's a stalk test, this one, so single leg stand, then extension, and we're looking for reproduction of symptoms on the symptomatic side. Back down again, same on the other side, and extend backwards. Perfect. Okay, so that would conclude our